Hello and good morning, good afternoon, good evening, wherever you all are. Thank you so much for making the time to join us today for a conversation around the new Discharge Playbook. We have a tremendous hour of content curated for you today. So I wanted to just take care of a couple of housekeeping items. This will be recorded and available after the presentation. I want you all to be thinking about any burning questions you have and put it into the Q&A because we will try to make time for a live Q&A session at the end. And without further ado, I wanted to go over our agenda for today. We're going to do some quick introductions here. We have some fabulous speakers joining us today. And then we're going to talk about where we are in the larger process of the discharge. It means a lot of things to a lot of people in a lot of different settings, but ultimately it's used as an episodic point in time. So we want to take a look at how the University of Iowa and Virtua Health are thinking differently about that moment. And then we're going to step back and have a conversation around what lessons we have learned up to this point and maybe where we're going in the future. And then, of course, as I mentioned, we'll have for time set aside for an audience question and answer. So without further ado, if I may ask my colleagues here, Dr. Blum, why don't I start with you? If you could do an introduction of yourself.
Yeah, well, thank you very much for inviting me to be here today. I'm Jim Blum. I'm the Chief Health Information Officer here at the University of Iowa. I'm an anesthesiologist and ICU doc, but I spend most of my time doing healthcare IT, looking for new technologies to bring into the organization to enhance the care we provide to all of our patients.
Fantastic. Thank you. And Michael?
Hi, I'm Michael Capriati. I'm the president of Advanced Care Operations and Logistics here at Virtua Health. I oversee our Enterprise Care Logistics Center, which includes our throughput and capacity and bed management areas, as well as our EMS system, as well as all of our care at home initiatives and our virtual care options that we're now offering within our facilities.
Tremendous. Again, thank you so much for the time in advance today. I look forward to our conversation. My name is Sindhu Pandit. I am one of the medical directors here at Best Buy. I am a physical medicine and rehab doc by background. And this is an ongoing conversation that's been sort of in front of us for a long time. So I'm really excited to dive right in. But I know there's always a question about what's Best Buy doing in health. And so I just wanted to make sure we kind of touched on that. The move into, moving healthcare into the home has been happening for some time now. And there's a number of reasons why that's been happening. Um, so what's driving this shift? We have a population that's getting older and that has more needs, but that those needs are also evolving and changing. So we're expected to have 82 million or so over the age of 65 in the next not that long from now. And then we're looking at 6 out of 10 individuals, adults in America, have a chronic disease, at least one. And then we're looking at, so if we shift from the population side to the resource side, hospitals are having constraint issue, capacity issues. We're seeing more individuals in the ED, but hospital beds themselves aren't increasing at that same level. And then we think about primary care and kind of what we've always thought about to be that quarterback of someone's health. We're expected to have a shortage, and again, these are not new points, but it's continuing in such a pace that we really need to start and a lot of us have already started talking about this, but continue to evolve our thinking around what care looks like, where care is delivered, and how best to optimize and up level the work people are doing to deliver that said care. So then Best Buy. Well, our purpose is to enrich and save lives through technology and meaningful connections. And Best Buy Health's goal is to enable care at home for everyone. And we think about the continuum of care in totality of an individual. So staying well, getting well. And there's a lot of things that happen along that continuum. It's really not episodes. This is one person evolving and trying to stay well. And in some instances, in the context of having a disease, manage that disease in the context of and trying to stay well. And that is the goal. And that's what we're trying to help our partners do as they deliver the care to these and to those that they serve. So what are we bringing to the table? What are our core competencies? It's technology, personalized services, logistics, and omni-channel experiences. And we bring that to the table to allow our partners to do what they do best, which is care for those that they're caring for. So if we shift back, I'd love to get a little bit more of perspective on Virtua Health, Michael, and then Dr. Plum, I'll come to you to get that same perspective on Iowa Health. Can you give us sort of a synopsis of the organization for those on the call that may not be familiar with your organization, and then also maybe touch on the how the partnership with Best Buy?
Yeah, sure. So I work for Virtua Health. It's the largest health system in Southern New Jersey. We're located about 15, 20 minutes outside of Philadelphia. We are a 5-hospital health system. We have about 15,000 employees. We have a very large ambulatory surgery footprint across our 3 states, both New Jersey, Pennsylvania, and Delaware, as well as a robust ambulatory network, a home health network as well. Our engagement with Best Buy Health started in 2022 as we started our journey with hospital at home. And we're looking for a vendor to partner with as we were applying for the CMS waiver and building out our program. So we've been running our program since that time and have expanded pretty dramatically, and excited to talk about that today.
Thank you so much. And Dr. Plum?
Yeah, so we're at the University of Iowa Healthcare. We're really we're the only academic medical center in the state of Iowa, and we provide the vast majority of the tertiary and quaternary care for the state of Iowa. We have now we're a 3-hospital system with a ivory tower, 862-bed academic medical center. We now have a community hospital across town, and we just opened literally at the end of April a orthopedics hospital, all located in eastern Iowa and Iowa City. But we have clinics that extend across to almost all counties in Iowa, providing services to really anyone in the state that needs those high-level services. We've been engaged with Best Buy for a number of years, predominantly looking at how we can accelerate early discharge from the facility. We did not apply for a hospital home waiver. Really, our strategy has been to reduce the time to discharge for those patients that are admitted to the facility. For a variety of reasons, we just didn't think that the waiver made a lot of sense given the geographic breadth of our patients.
Thank you both for that perspective. And that's fantastic. It shows like when we say hospital means a lot of things. And just to hear with both of you, you have very different perspectives. And of course, a shared North Star in caring for your patients, but the challenges that you deal with and perhaps even how you approach challenges that would be shared will be different, which is why we wanted to talk about this particular point, because I think it's really important in how we start thinking about discharge. So, discharge I mean, when we think about discharge, it's that perspective of a person in a bed and their loved ones are coming to pick them up, and you have an individual go there with the papers and give them the papers and say, okay, thank you. But we all know that that is not truly how that is in that person's life, how that moment works. As we think about sort of the larger perspective here, in the discharge, in that moment, it's seen that about 80% serious medical errors are due to miscommunication. 60% of patients report confusion or lack of confidence in understanding those instructions. And in the most recent study, we've seen about 14% readmissions still occurring after discharge, and that's CMS data. So, this is an ongoing issue, and a lot of information is given in that moment, and it's hard to digest all of that and then maintain in your mind all the different things that you need to follow up with, keep, adhere to, and understand who you spoke to in all of those different conversations, and then you're on your way. So, as we start thinking about how do we approach this moment differently, is really it's a continuum for that individual in that person's life. So as we're thinking about the headwinds, we have value-based expansion happening. Of course, that's been going on for some time. The workforce strain is real. I think both of you will speak to this in a bit, but I mean that's a palpable challenge across the board. It's a changing landscape of those who are able to provide the care, and the consumerization of care is now an understood requirement. People want to receive care the way they want to receive it. And we have to acknowledge that in the way we're delivering instructions, care, and sort of all of the different touch points that follow through. So when we step back and say, okay, the traditional mindset, discharge is one and done. And we know that's not right. That's not what happens, but it's how it's sometimes perceived by the patient and their family. What we're going to talk about today is maybe changing the mindset a bit. And this is a really important place in my heart, because I'm a post-acute doc. I'm a PM&R doc. I work in the post-acute setting. And even that word, the post-acute phrase, has evolved over time. You're not always post an acute stay. And so we have to start thinking differently about where our patients are in their journey of health management and then staying well, and then start to think about how we can evolve our systems to support that. So you have the acute care admission, and then we can talk about this, and this is where both of you have done a lot of innovative or challenged the model and done some innovative things, is to think of that discharge moment as a transition, and then think about the phase 3 of that care episode for the follow-up appointments, medication management, education, resources, and truly thinking about this as a continuum. So what if you don't do this? What if we stay with the way things are, because that's how our models are set up, that's how we're trained. What does a readmission cost look? What is the cost of a readmission? So when we look at the costs, it's pretty daunting, honestly. It's approximately, if you average out an all costs, all diagnosis, all cause readmission, is somewhere around $15,000, and that's something that we need to not lose sight of. And then if you extrapolate that over the numbers that could be present and for a particular organization, it's something to look at and look at seriously. And are there other things that we can do to kind of address that? So with that, I'm going to pause and come back to our esteemed panelists. Dr. Blum, why don't I start with you? We've had some conversations about this, and you have uh, some interesting challenges that well, maybe not interesting, there are your challenges.
Yeah.
But
Yeah.
I'd love for you to sort of give your perspective on this topic, but then also maybe even take us to that first use case where you thought about, maybe this is a place we should really revisit and optimize our discharge our discharge process.
Yeah, so we're very fortunate in that we have a really fantastic physician base here that's incredibly committed to their patients, and really I think has a approach to care that we really want to make sure that we're doing what's right for the patient, regardless of the potential cost of care. And being that we are caring for people, over half our patients are coming from more than 90 minutes away, up to 4 or 5 hours away, depending on where they are in the state of Iowa. So we have a historically very long length of stay for an organization. If you look at us, we've historically run sort of 1.2 to 1.4 times the predicted length of stay for most of our admissions. And a lot of that is associated just with the concern, particularly of our surgical services, of them saying, you know, I just want to make sure this patient's okay, particularly in high-risk readmission cases like colorectal cancer, right? And they say, I don't want my patient to winding up with post-operative infection, getting concerned about them, and winding up in some ED in a 25-bed critical access hospital, getting critically ill because we weren't able to keep an eye on them appropriately. And so, for example, our average colectomy or partial colectomy length of stay was measured at about 6 days, which is quite long for routine operations. And we were really looking for ways to address that. And so we had a great group of surgeons that said, if you could get me better awareness of what's going on, and I knew my patient was being watched, I would be willing to send them home earlier, assuming that the patient was well prepared and packaged. Oh, and by the way, it's not going to be too much work for me to watch them remotely, right? You know, so we partnered with Best Buy, and we really had a great experience in demonstrating the ability to send patients home in literally half that time, about 2.5 days. Our surgeons were happy to send that group of patients home. It was a huge success for us as an organization.
Thank you for sharing that. And when I think about that 90-minute drive, just to be able to support that patient and that family in that sort of a digital hand-holding experience, I think it gives just a different. I mean, it is an evolving conversation, of course, but the trust factor there is just. It, I think it really up levels that trust factor between the patient and the system. Michael, what are your thoughts on kind of what Dr. Blum shared, but also with Virtua? Like, how did you start diving into this space?
Yeah, I think it's great to hear about new use cases for discharge support in the home. We came about our care after discharge program slightly differently. We were in the throes of COVID surges in 2021 and looking for ways to help relieve some of the pressures that we're facing in our organization, as many organizations all were facing across the country. Combined with the Great Resignation and looking for alternate career paths, and combine that with the fact that we believe that anywhere between 20 and 25% of all care will move into the home in the next decade, we kind of jumped headfirst into this hospital at home journey and propped up a hospital at home program in January of 2022. So we had talked to our executives about investing in the program as an innovation model and what could we learn from it and how could it change the way we approach care as an organization. But in reality, looking at the program, we all know that scalability and growing scale is key when you're making that kind of investment. So in our first year of hospital at home, we did really well. We thought we would see about 100 patients. We saw a little over 300 patients in that first year. Which was good, but we had this tremendous infrastructure, and we were starting to notice just how our patients felt at discharge, because we're in their home and we're seeing it, and they're having all these resources available to them, and all of a sudden, they're gone. We're done. They're discharged. It's over. And their care stops, and they go out into the ambulatory setting, and we hope that they get the care that they need. So we decided that there's probably this window, 24 to 72 hours post-discharge, where we could take this group of physicians, nurses, and infrastructure that we put in place and maybe handhold our patients slightly differently through that discharge process. And that's our care after discharge program. Essentially, what we built was a 24 to 72 hour transitional care unit, for lack of a better word. They are discharged. It also got us out of we became payer agnostic at that point. We weren't just tied to Medicare, and we could see more patients. And we basically go to our patient's home. We transition them either from the hospital or from hospital at home into our program. We have a hospital at home tech, which is a paramedic, go into their home, set up their their Best Buy health kit. We do continuous monitoring for 24 hours. We do a set of vitals while we're in the house. We do a in-home med reconciliation. And then they see one of our hospitalists within 24 hours of discharge. It has been an absolute game changer for us. So I joke sometimes with our board or executives and say, I feel like it's the chocolate that fell in the peanut butter for us, because we really, it's a win-win for everybody. We were in the throes of an excess day issue and length of stay issue as well. Everybody probably faced that during and post-COVID. So we're pushing our physicians to discharge earlier. This provided them an option to say, hey, you know that patient you're transitioning from maybe an IV to an oral med, and you want to watch them for 24 more hours? We'll watch them for 24 more hours, but in their home, discharge them. And we can safely do that. So we saw a reduction in length of stay of upwards of at least a day to a day and a half. But I think the other magical piece was the reduction in readmissions. We are today in our program seeing about a 9 to 10% total readmission rate, and our case mix index has continued to grow in our program as we become embedded in our organization in our readmission initiatives, as well as many other initiatives to help our patients transition to home. And it's been an absolute game changer for us.
Oh wow, that's pretty incredible results. And you touched on a couple of points there, and Dr. Plum, you mentioned it as well. We often talk about technology, people, and process, and it's all required. It's kind of like the symphony of change management, if you will. Dr. Blum, if I can pull you into this for some of the points that Michael made, he talks about the Great Resignation as it was dubbed some years ago. How did you think about the people side of this? Because on the patient side, we talked about the trust factor and how it takes forever to build it and takes a moment to lose it. So, extending that digital hand-holding experience into the home is so critical, and to do it right, it's so there's no it's not non-compromise. Like, you cannot compromise on that. So if you could talk about the people side of that, like, how did you do the cultural shift internally to start thinking about this as a model? You mentioned the surgeons were on board. Can you go through a little bit of that thought process? I, I, th-
I am
I
muted.
think you're
Sorry about that.
right.
Yep.
Yes.
Yep. There we go. I think what you mentioned there, I think really having your providers buy into the concept is the number one aspect. And so we were very fortunate to have a group of surgeons that said, we're willing to be innovative, we're willing to partner with you, and we're willing to trust you with this. With that said, they had a couple of conditions. The first of which is, we don't want to be the person being the people answering a call that's coming from someone that's monitoring the patient, right? And we want to have a trusted patient. We want to have someone that we can trust monitoring the patient, right? And it can't fall on our team to be the people doing the monitoring. So that's really where the partnership with Best Buy was fantastic, in that we were able to offload the initial monitoring to your team. That enabled us to, they did a fantastic job of keeping track of patients. If patients fell off monitor, they reached out to them. That wasn't us having to do that type of work. And really the phone calls that we got were then managed by a central triage group that I manage, that was able to ascertain what was going on with the patient. And then only then, when we really had a problem, would we go ahead and contact the surgeon and the surgeon's team and say, hey, we think we need to do something regarding this patient, or what do you want to do regarding this patient? And that was really that system of care with those people, it was that process and those people that enabled it to happen, which we wouldn't have been able to do without the assistance of Best Buy and having that monitoring team available for us for what really is a relatively low volume operation.
Were there any things that your care team, your clinical team, including your own, like, thought, oh, I wish we were still doing it the way we did it? Or was it
Um,
like when you got in your full speed ahead?
I think we did have I think there were, as a system-wide approach, no, I think there were a couple of patients, we had some people that were continuously, not monitoring, they're taking off the monitor, I'm gonna be free, whatever they were thinking.
Yeah.
Not have Big Brother watching me, and, then you're facing this debate of what do we do? Mr. Jones was doing fine. Now he's off the monitor, we've tried to call him, he's not answering his phone. What do we do in that situation? Fortunately, we had he was a relatively young guy, and we knew his mom, and she said, yeah, he's over here, so it was fine. But those were sort of the headaches that you deal with. But as a whole, we thought the system worked extraordinarily well, and we're very pleased with the outcomes. So.
No, I think it brings up the human behavior and the human
Yeah.
element of this, right? And I used to tell my residents, you writing the prescription is not the end of that conversation. The patient actually has to take the medicine, so it's not losing that sight that there's still a compliance adherence situation or requirement in this, but it's a bit different. But we're trying to meet the patients where they are, which does take us looking at this whole model a little bit differently. So, Michael, to your point about kind of some of the staffing challenges you had, and we've talked about cultural shift internally at Virtua. Can you comment on
Yeah.
some of the experiences that Dr. Blum spoke to as well?
Yeah, I think Dr. Blum nailed it. I think one of the really cool pieces about how we built our program is we built it out of our hospitals and through our hospitalist program as well. So we had out of the gates, we engaged and assigned somebody as our medical director who was going to partner with us clinically. Our nurse leader came from our divisions. We birthed this out of our divisions. So as we were going out there and trying to engage in interdisciplinary rounds, as we were trying to
Yeah,
get buy-in from physicians and other groups across the organization, it was coming from a trusted resource. And they were understanding that this is, part of these are people they were just working next to, a few weeks ago. The other piece that we do too is all of our physicians who see our hospital at home and care after discharge patients are the same hospitalists who are rotating throughout the hospitals. So we do have a few dedicated, but then outside
yeah,
of that, we have our hospitalists within our divisions actually rotate through the program. And I think it's been absolutely transformational for us as an
yeah,
organization because they're now seeing their care in the hospital and the effect of it in the home. And I think it's changing the way they approach their care in the hospital. It's no longer this episodic, I'm going to get you out and hope and pray that you do well out in the community. I think they're seeing the impact of how they manage the care in the hospital and the home differently and changing their models slightly differently. So it's been transformational in a lot of ways for us.
that's incredible. So thank you so much for walking us through like how the journey started for you, some lessons learned, and sort of where you all are at now. But we have a lot of listeners today, and if you were to say, let's start with maybe three things to consider from each of you as we think about a playbook of sorts to start thinking about their program and not just starting the program, but if they're further along scaling the program, maybe what are components that they should consider to a program that supports discharge to home or discharge to care at home. Maybe Michael, I'll stay with you.
Yeah, sure. I think the physician piece is key. Not just physician buy-in, but physicians that are embedded in the program. I think that your program has to solve a problem that actually makes sense to everyone. It's not just because you want to do something in the home. There has to be challenges that we're facing that we're trying to address with this as a service. And from a scalability part, I think at Virtua, we learn every time we grow our volumes. And I think the hardest thing to do if you haven't started is to start, and you can get stuck in analysis paralysis, and you're never going to plan for everything you're going to face when you start to bring care in a home. So my recommendation is start and learn, create a model that adapts and evolves with you, and make sure you find people and leaders that are working within your program that are comfortable in that, because not everybody's comfortable there. But that scalability and starting, you're never going to plan for everything you're going to face at all the different levels.
Oh, and that is the songbook for medicine. You're never you can't plan for everything you're gonna face.
No.
Um, Dr. Plum, your thoughts for our those that are joining us for their playbook as they start to write it out.
Yeah, I think what Michael said was exactly right. I think there's also I think having the medical teams know what they're going to do and be comfortable with the idea of going into it with the unknown is a key element. And you need people that are going to be agile and able to adapt to the situation. But I also think there is value in planning, right? The plans may actually be useless, but the process of planning may be, very helpful, right?
Very good point. Yeah.
When we did this, we sort of started from the idea of, okay, how are we going to get the patient the device, right? And you're going to have someone that has a new, they're going to have a minimum of an incision, if not an ostomy. They're going to be on opioids. The last thing they're going to want to be doing is carrying home some type of device that we give them to carry out the door, right, with their family member. So we actually shipped the device to them ahead of time, right? And we got them set up on monitor. We knew it was working. So there was no someone having on opioids, in pain, all these other things, trying to figure out how to get the device set up and working. And that also meant that we had to choose the right patients. So if it was someone that was still walking around with a Motorola flip phone, we probably weren't going to send them home with, we probably weren't going to send them all this fancy technology, right? So we were able to choose the right patient population that was going to be successful with the technology. And then we had a fairly clear plan as to when the patient did veer off course, how were we going to deal with it? Who was going to get called? What was the management? Were we going to refer them to their local facility for initial triage, or were we going to say, just come back to us? And what were our criteria for doing that? And I think that was very helpful in that we had thought through the situations that were likely to occur. Those were the situations that occurred, and we were able to triage people appropriately. Then we got people in there. We got one patient. We only had a couple of folks that got into trouble. One of which we avoided getting readmitted by getting them into a clinic, seeing their surgeon, being evaluated, saying, yes, this is a superficial wound infection. Let's get you started on antibiotics. We had another patient that was getting kind of dehydrated just due to high ostomy output. They came into the ED. They did get admitted for a very brief period of time, technically observation level of time, got rehydrated, managed, and sent home. So those were the types of things that we were able to do, but we had that playbook at least thought through, if not completely written down. And we didn't know exactly what was going to happen, but we were able to execute appropriately in collaboration with the primary surgeon and our triaging physicians. So.
That's so interesting. And I love being able to go broad at the program level, but also looking at those individual cases and thinking through, was there something else we could have done here, or how could we do something differently? Like you said, pulling them into clinic to support a visit. And I know, Michael, you talked about the virtual visit component to it. So figuring out when the modality or which modality is right for which scenario, which is really interesting. Dr. Blum, staying with you, you have, through this conversation, talked about a couple of different metrics. What were some of the metrics that you've laid out to determine whether the program is going in the right direction? And what does success look like to you now, kind of where you sit and
so the number one
perspective?
The number one metric for us was safety, right? So we wanted to make sure that we did not have at any point that we felt we were placing a patient at risk. And so throughout our experience, we never felt that, as we gained more experience, we felt very comfortable with sending people out early, and making sure that they weren't going to be at risk. And as we had those couple of early saves, right, we really felt that that was representative of the fact that we could provide that near hospital level of monitoring with people at home. And that we felt very comfortable with. The second aspect that I think was, for us, our KPI outside of making sure the system was safe was, did we impact length of stay, right? That was the question. And so that impacted. We knew we would backfill because we're always at 100% capacity here, 100+% capacity. So obviously there was a financial ROI calculation that if you weren't running at high capacity, like, is this actually saving you money, right? That would be a reasonable question. But we knew there would be a backfill to that bed. So we knew instantaneously that the program was going to be, if we save days, we would return value to the organization. And so those were really our two KPIs that we followed and were able to deliver on.
Thank you for sharing that, Michael. From your
Yes.
perspective at Virtua, how did you approach metrics and have
Yeah.
kind of what does success look like to you?
We were looking at, obviously scalability, how many patients we could get into the program safely, as Dr. Baum said. Between our two programs, this year we'll probably see close to 5,000 patients in our two programs between hospital at home and care after discharge. But we look at also, are we truly reducing length of stay? And we track that very closely. We've been between a day and a day and a half in both programs, actually. And then we look at readmission rates as well, and in combination with case mix index and our DRG mix that we're seeing in our program. So, and we've seen great success through that in greatly reducing our readmission rate, I think. But I also think there's the other pieces of patient satisfaction and what our patients are telling us. We get a tremendously high Net Promoter Score. We see improvement in clinician communication, preparation for discharge, all those things that we have been struggling with a bit in our organization. But I think also it's a little more anecdotal, but we track our clinician satisfaction as well. Our nurses that are part of these programs, this is team-based care at its best when you're doing virtual care. And so many of our nurses tell us, like, this is what I went into nursing to do. I was getting burnout on the floor, but this is so interactive, and I'm working as a team with our clinicians and everyone, that I really feel empowered and renewed in my nursing journey and my career. And our physicians are telling us, like, I'm learning so much. When we went into this, we thought this was going to be sterile. Virtual care is across the screen. And they're finding it absolutely the opposite, that they're in people's kitchens, they're in their family rooms. They see their family members more often, like when they're talking discharge, they're with their spouse or partner. They can see their dog and talk about the dog. And so it's, it's the hard metrics, but I think there's a lot of other benefits that that maybe aren't as trackable as those hard metrics, which are great.
Oh, I absolutely love that. It's really speaking to the discharge more as the transition point as opposed to the end point for both of your
Yep.
programs. And
Yep.
that shows, both of you called out the family, both of you called out their home environments. And these are things that would be, two-dimensional on a piece of paper, but now we see it in their world, and we're not creating the discharge for the hospital bedroom, or the hospital room, but their home bedroom. So I think it's pretty phenomenal. So any good playbook has what to do, but how about what not to do? Do you guys have any advice for our colleagues on the phone today? Maybe Michael, I'll stay with you. Thoughts about what to put in there in big letters on what not to do.
Oh, I have to think about that one. What not to do. I think trying to start a program without physician buy-in and clinician buy-in, I think, is one of the biggest. I also think, continually monitoring the voice of the customer. You have to constantly do that and learn and evolve.
Excellent. So, yeah, learning feedback loops as we
Yep. Feedback
love.
loops for sure.
Um, Dr. Blum, your thought for that, what not to do part of the playbook.
Yeah, I think one of the things is that as you proceed with this, it becomes successful. And then you get to the question of how do you scale, right? And this is actually where we have had that. We've had the question of, okay, where do we go next? Who's the next organization? And then when do we flip the switch and how do we scale away from potentially contracted monitoring services to internal monitoring services?
Mhm.
Um, that's something we're now trying to think through. What do those things look like? And it's been more of a challenge than you would think, particularly given the work environment that exists today, the nature of the people that you're going to have potentially doing the monitoring. How do you provide 24/7 support? And those are questions that come forward that people just need to work through. And I think it's going to be different depending on your labor market, what you already have inside your program, and the nature of the patients that you're sending out. Um, it's very different, I think, sending out a group of heart failure patients that have a very high rate of readmission and potentially a set of needs versus a set of post-operative surgical patients that really, in many ways, you're treating the surgeon just as much as you're treating the patient, right?
Yeah.
And so those are very different needs, and how do you provide the service? Because those are different things, but you need to do it with the same team. So those are the things I think are important for people to think through, and something we would have done differently. So.
Well, thank you so much, and just such immense insights shared today. With that, I'm actually going to go to our questions that are coming in from our audience. Actually, Dr. Blum, I have one for you, and it kind of is a nice follow-up to the statement that you just had. When are post-acute services included in sort of or discussed as a part of the plan, the pre, the during, and the post-op plan?
Yeah, so so for us, it was discussed entirely prior to the hospital admission, right? So it was done in clinic with the patient to understand, are you interested in this? We're going to try to get you home earlier. Tell us about your living condition, because we want to make sure that they were going to be safe at home. We didn't want them doing all this on their own. They need to be technologically a little bit savvy, even though the device was delivered and easy to set up and there was lots of support. So all that happened ahead of time. Literally, the patient was discharged home, and there was not one mention of the technology their entire stay in the hospital. They knew what to do when they showed up at home. Put the device on, put your heart rate monitor on, take your blood pressure. All that was done well ahead of time, and so they weren't burdened with that during their recovery.
No, I think that's really important because again, as you go further along in your case, the procedure, or in any other case, kind of the intervention for the condition, why they're in the hospital or in a hospital type environment to begin with, the ability to absorb all that new information, you're just not in that same state. And so I think it's really respectful to kind of go upstream a little bit and troubleshoot questions as they come up, because they will come up again, but starting earlier and kind of helping that person through the journey as opposed to dumping all this information at the end. No, that's great. um, so I've gone 43 minutes without saying AI, but we have a question. Um, Michael, I'll start with you. How can AI be helpful to ensure the human connection is enabled, time is unlocked, and broader cultural understanding of a family in their home? When we're thinking about patient-centric or family-centric, is there something we can do leveraging AI tools?
Well, for us at Virtua, we're using AI to help us screen for who would be appropriate in our program. So we've developed an AI tool to help us really hone in on those patients that would be appropriate for hospital at home, and then our care after discharge program as well. I think AI plays a role moving forward too in our ability to scale better and spend more time, less time with continuous monitoring devices and more time face to face with our patients. So I think from our perspective, we see that enables us to get more patients into our program. AI helping us monitor all the continuous monitoring, and then allows our nurses and our physicians to spend more time with their patients face to face. That's how we're looking at it.
Oh, fantastic. And Dr. Blum, your thoughts?
Yeah, I think from the treatment side of things, I think AI, particularly when you have, as Michael said, this is really the pentultimate in team-based care. So you're going to have patients that are out there that people aren't necessarily going to know a lot about, right? And discharge summaries being what they are, and comorbidities being what they are. I think there's an opportunity to really leverage AI tools to take that data that is coming from the device, but also from the entire EHR, to get a better understanding of, okay, for whatever reason the patient triggered, we're having a discussion about what to do, what might be the issue, and how do I need to manage that? And I think being an ICU doc and having done a lot of time in doing it in an EICU that was not AI enabled, right? You would spend a lot of time digging through charts, trying to figure out, what was wrong with Mr. Jones before he became critically ill. The same thing is happening in these environments. So leveraging those AI tools to get a better understanding of the patient when they do need to be triaged remotely, I think is where there's a real opportunity here to leverage those tools that are coming on the market today.
That's interesting. Again, it's such complementary perspectives, but I think we'll all continue to evolve and seeing where I think that the through line, if I'm hearing you both correctly, is that we're all just trying to unlock that human interaction, allow our colleagues to do their job better, and to give them more time to interact and connect with those they're serving, the patients they're taking care of. So we have another question here around family caregivers. So how do you both think about the caregivers, the family, and the home, in both the design, the adoption, and consideration of getting a person in the home, a patient in a to care for them in the home, um, and how do you kind of include them? Do you take questions from the caregiver? Do you engage the caregiver directly? Maybe Dr. Baum, I'll stay with you.
Yeah, with our program, we would really prefer that there was someone else in the home with the patient. Part of that was just our surgical colleagues were, it made them a little more at ease to know that in addition to the technology watching the patient, there was going to be someone else at home, right? So it lowered their anxiety. And that was useful, as I gave the example of the patient that just decided to go AWOL on us. So those are the types of things where we felt having someone at home was a big help. In addition to the fact anyone post-surgically, we think particularly, they're going to be encumbered in some way, shape, or form. Having that additional help at home, particularly in the first few days of recovery, is invaluable.
Yeah, good point. Michael, your thoughts?
Yeah, I mean, the home environment and the family or caregivers, partners are critical in the conversations. We actually pull them into the conversation when we think that their loved one is a candidate for any of our programs, either hospital home or care after discharge, and have a family conversation. We've been cameraing our med-surg units now across our organization, and we can actually send family members a link that we can pull them into a conversation virtually with the patient in their room and talk them through. We even have a video that we show to them. We want them all to fully understand what everybody's role is in this, because there is a role for the caregiver. And what it will mean to their loved one going home. So it's a critical part in preparing somebody fully for going into our care after discharge program, for sure. And they have to be a part of that conversation, and there has to be buy-in from all parties.
Yeah, no, absolutely. So I'm gonna combine two questions here. It sounds there's some um, commonalities being drawn from what we're talking about here to traditional post-acute options. So the question here is, do you still consider post-acute, traditional post-acute options for your patients who have entered care after discharge, hospital at home, or a post-surgical discharge plan? Michael, I can stay with you on that. What are your thoughts, like home health,
Yeah.
therapy, those types of things?
I mean, interestingly enough, we see in our programs a reduction in skilled nursing utilization because people just recover differently in their home. But it is constantly a part of all of our clinicians' thought process. And what we're finding is we're actually catching, because we're seeing the patients again. We talk about this, like the
Yeah.
uniqueness of seeing them in their home and seeing them in their home environment. We're catching a ton of post-acute needs that maybe weren't necessarily identified in the facility because you just don't know what they're facing in their home. So we are constantly integrating and referring to home health. We have seen patients that were like, they really should go into a skilled nursing facility, and family members push back, and we can really see it and have a really good conversation about their environment and why they need
Mhm.
that. But I think it extends even past that to DME needs, oxygen needs. We find patients who desat when they get home, who didn't desat when they were in the hospital for whatever reason, and that would have been readmission. And then there's hospice and palliative care, which we don't
Oh,
necessarily address as much as we can or should maybe in our facilities, where we see
that's a
the
good point.
patients and their family in the home, and we're like, hey, we can have a more informed conversation about maybe the next steps for their loved one.
Yeah, no, that's such an interesting point. Uh, Dr. Blum, your thoughts?
Yeah, I think in a robust program like Michael's that's really focusing on I would say a much larger swath of the population, you're going to see a greater need for these types of discussions. On the procedural side of things, um, a lot of the home health needs are really kind of almost decoupled from the concerns that we have of just accelerated discharge, right? So if you were going to need home nursing on day 2, you were going to need probably on day 3 because of whatever issue it was. It's not like we're catching that, and we typically are aware of most of those things that are going to occur in the perioperative environment. So I think it's a different element. And
Yeah.
I definitely think you probably need to be a little more agile if you're dealing with the medical side of things and trying to get people out the door on the medical side of the house than on the surgical side. So
So I'm gonna just stay with you, Dr. Blum. There's a question around the clinician and the patient experience. So do you have both virtual and in-home visits made by the clinical team? And then also, do you consider other sort of home aids or whatnot to bolster the care in the home for your
yeah,
postoperative patients?
great question. So our surgeons did not change their behavior one iota. That was other than so their thoughts were, I don't want to be sitting in front of a computer because that's going to add more time to my day, right? I want to run through the hospital and see all my postoperative patients. And if you can't take them off my plate entirely, I want them to stay here because that's how I'm going to be most efficient.
Mm.
And so literally their thoughts were they leave the building, we're doing nothing to do with them unless somebody in triage thinks they need to come back, right?
Okay.
With that said, we did leverage where necessary, as they would with any discharge, home nursing for ostomies or fluids or anything like that. All of those decisions were made ahead of time, and it literally was decoupled from the monitoring program. The
Yeah.
monitoring program that was there as a safety mechanism, as a tool to help the patient get home. All the surgical decisions were made regardless. Post-operative management decisions were made regardless of monitoring versus no monitoring, which made it very lightweight and easy to start, right? Because
Yeah.
all we were saying to people was, do what you do on a daily basis. Just consider sending your patient home early because you know they're going to be safe.
Yeah. No, that's great. And Michael, your thoughts, or if you can comment on your clinical
Yeah,
teams.
sure. We do in-home visits in hospital at home with our nursing team, but our care after discharge program is fully virtual. We have actually been discussing home health aides. We've been growing so much that if somebody doesn't have the support right now, we're kind of putting them out of the program. But we have been talking about health aides and how we incorporate them to like open it up to a broader population for sure. I could certainly see that in our near future.
Well, I mean, I can't believe this, but we're nearing the end of this conversation. That went really fast. So, what I'd like for both of you to think about is maybe parting remarks. If you both could leave, think about like that one pearl or that one message you want to leave our listeners with as we sort of wrap up today's conversation. Thinking about what our conversation has covered, or maybe even something else you want to touch on before we go. So, Michael, I'll stay with you.
Yeah, sure. I would say don't underestimate how transformational a program like this can be for you and your organization. I think thinking about it in isolation as just a hospital at home or care after discharge program, I think is a mistake. I think it's completely changed the way we think and about even our care in our bricks and mortar facilities and how we can deliver it differently. We've engaged in, like I said, cameraing our entire med surge, our ICUs now, all because of lessons learned that we did in the home. And we said, if we could do this in the home, imagine what we can do in our bricks and mortar facilities to support our
Yeah.
clinicians and our families differently. So I would just say, view this as an innovation opportunity, not just a service development that you're putting into the home. And I think if you look at it that way, then you're talking true transformation for your organization.
Oh, fantastic. Dr. Blum?
I agree with Michael. I think that this is an opportunity to really pivot your organization and
Yeah.
understanding where the needs are in your organization and what you're trying to address early on, build around that, but then look for the ability to expand the program beyond that is really where the magic's going to happen for you and your system.
Well, thank you. I will be putting together all of these notes and into a playbook and be, no, just kidding. But we will be sharing the recording of this conversation to all of those who joined and took the time out of their schedules to be here. Thank you so much. And, it's so much gratitude to you, Michael, and to Dr. Blum, both of you sharing your insights and being so forthcoming with your lessons learned. I mean, it's truly invaluable and truly appreciate that you were able to join us today. There will actually be some case studies available for our audience to download. And again, this is an evolving conversation, and I look forward to touching base with both of you in some time from now and seeing how things are going so that we can all continue to learn and grow and expand the space. And with that, I will hope all of you have a terrific rest of your day. Thank you so much.
Thank you.
Thank you.